Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today's guest is neurological physiotherapist and educator Narelle Dalwood, and this is Narelle's third time on the podcast, I believe. And I've had several requests from people online and in person for more episodes with Narelle, and specifically more detailed exploration of some of Narelle's expertise in neurological physiotherapy and exploration of the topic. So it's a pleasure to have her back again on the podcast. Narelle Dalwood, welcome back to Physio Foundations.
Thank you very much, Luke. It is a pleasure to be back. Always happy to talk about all things neuro.
Let's talk about some of the common neurological conditions that physiotherapists help people to manage. So this is such an open, broad question. We can start anywhere, but go for it.
Absolutely. And it's interesting because certainly as you said, I'm an educator, and certainly when I work with students and young people coming into physiotherapy, most of them don't know really anything about neurological physiotherapy unless they've been in a situation where they've got perhaps a family member, or perhaps if they've done some sort of allied health assistant work. But generally for me, that's an exciting part of my job, is introducing students to the fact that we work with people who have damage to their brain or their spinal cord or their nerves, sometimes all three. Probably I would say the most common pathology that we work with is people with stroke. But then, people with traumatic brain injury, spinal cord injury, Parkinson's disease, multiple sclerosis, Guillain-Barré syndrome. And then, of course, there's the pathologies like cerebral palsy, muscular dystrophy, spina bifida, which, sort of historically have been more in the pediatric realm. But, of course, people with cerebral palsy grow into adulthood, and I know that you've done a podcast with Prue Morgan, who's an absolute specialist in that area. So that's a bit of a rough outline. There's lots and lots of different types of pathologies that we work with, but they'd be some of the most common.
And this is an episode for getting into those foundational principles and neuroanatomy, the common impairments and functional limitations that people have. And if people want an introduction to you and your background and Prue's background that you mentioned, they can go back and find the previous episodes. I wanted to get straight into the content today. So why don't we start with the areas of the brain that can be commonly damaged, for example, with stroke, and how that relates to the impairments and functional limitations we see. So we can keep it really basic. And then if something's interesting, we can dive into the specifics.
Yeah, sure. So, for example, with stroke, probably one of the most common type of stroke is what we call a middle cerebral artery stroke. So it is really important, as a physiotherapist, as we know, knowing your anatomy, is really important. So, for example, let's go with middle cerebral artery, because it is, as I said, one of the most common types of stroke. The middle cerebral artery supplies the lateral hemisphere, the lateral surface of the hemispheres of the brain, and generally will supply areas of the frontal lobe, the temporal lobe, and the parietal lobe on that lateral surface of the hemispheres. So then in terms of using your neuroanatomy, you then look at, okay, so what's on the lateral surface of the hemispheres? And for example, importantly to physiotherapists, the motor strip, what we call the motor strip, sits in the frontal lobe. Well, it sits in the, sort of the posterior part of the frontal lobe on the lateral surface of the hemisphere. Similarly, the sensory strip, so all sort of, the area for all types of sensation, sits in the parietal lobe. It actually sits very close to the motor strip, but just turns out they sit in different lobes of the brain. One is in the back part of the frontal lobe. The other one is in the front part of the parietal lobe. So that's a long way of saying if someone has a middle cerebral artery infarct, one of the key areas that will, that's why people will have motor symptoms and sensory symptoms, because usually both parts, both the motor strip and the sensory strip, are affected. A patient with a middle cerebral artery infarct will often have visual disturbances as well. Now that when you first think about it, you can think, that's weird. I thought that the visual processing centre is in the occipital lobe at the back part of the brain. And it is. But if you think about it, the occipital lobe sits at the back part of the brain and your eyes sit at the front. And, of course, all the pathways from the eyes to the visual processing centre at the back of the brain have to pass through the other lobes of the brain. So, again, long way of saying that people with a middle cerebral artery stroke will often have visual deficits such as homogeneous hemianopia, where they lose the ability to process or see one half of their visual field. And then, of course, obviously if someone has a right middle cerebral artery infarct, all of those impairments would be on their left side. Then you've got extra stuff, of course, like language centres. So you've got Broca's area that sits in the in the frontal lobe on the left side of the brain, and Wernicke's area, which sits in the temporal lobe on the left side of the brain. So specifically, people with a left middle cerebral artery infarct very commonly have language deficits as well. Brains don't read textbooks, so sometimes I just said that the language centres usually sit on the left hemisphere of the brain, but not always. For some people, they actually sit on the right, and that's a sort of a whole other kettle of fish that we could potentially get into. But generally, you'll find that people who have a left middle cerebral artery infarct will also have language deficit.
And you mentioned textbooks there, and I'm guessing you learned all of this in a textbook back in the day, and now rather than listening to 7-second summaries on the internet and podcasts, but this is hopefully complementing the learning that people are doing. So as you were summarising that, you've done this many times, and that was such a nice summary of one particular type of stroke and the functional limitations that you can have. I was thinking of how heterogeneous many of our neurological conditions and strokes are, how different they are between people. So as a new grad, if you can think back to when you were first working independently, that's a really nice summary of a left middle cerebral artery infarct. But they're all different, right?
Yeah.
And the degrees of those impairments are very different. So how do you come to terms with that uncertainty, and how do you work together with other professionals and the imaging that you have and everything to bring all of that together and help understand that person's unique problems?
Yeah, that's a great question. And I'm actually I'll segue a little bit. One way so as you said, I just described middle cerebral artery infarcts and then focused on a left middle cerebral artery infarct. Obviously, in terms of strokes, lots of different arteries can be affected. So, the impairments that you would expect from an anterior communicating artery infarct or a posterior cerebral artery infarct will be different. You mentioned working with other health professionals, and I think that that's really important. And interestingly, it does depend on which area of the brain is affected in terms of which health professionals end up needing, being involved with the patient. So obviously if somebody does have language issues because of their, impact on the Broca's area and Wernicke's area, then as a physiotherapist, you're going to work really closely with the speech pathologist. For example, if somebody has an anterior cerebral artery infarct, they're much more likely to have what we call frontal lobe deficits. So problems with their cognition, their thinking, their judgment, their sort of executive function, if you like. And with those people, we're going to work really closely with occupational therapists and perhaps neuropsychologists, for example. And obviously, as a physiotherapist, I would work with other health professionals with all patients. But I guess that just gives you a little bit of a snapshot of how the actual pathology that somebody presents with, the area of the brain that's affected, and of course the impairments and then the activity limitations and participations restriction, got a bit tangled, will then really impact on what health professionals need to be involved. I will segue just a little bit. The other thing, as I said, said at the start that I was talking about middle cerebral artery infarct, when I'm working with a patient and when I'm reading their patient notes, and I generally do start with what is their pathology before I actually dive into who the person is, because knowing about their pathology, even before I've met the patient, really gives me a little bit of an insight, as a physiotherapist with a certain amount of years experience, I can predict in some way what sort of impairments and activity limitations a person with Parkinson's disease might be presenting with before I even go and meet them. Obviously, if I know that my patient has middle cerebral artery infarct, I can predict and anticipate what sort of impairments and activity limitations they're likely to have before I go and meet them. But then, as you said, every patient's different. And even though I go in armed with that theoretical sort of background and information and anticipating what to expect, my mind is always open because everyone is very different. And the other thing that I do when I read through someone's notes is think about, is this person presenting with an upper motor neuron lesion or a lower motor neuron lesion? Because again, the impact on the person's impairments and their activity limitations will be quite different depending on whether it's an upper motor neuron lesion or lower.
There's so much to unpack there. If you go back to the thinking about what you said about the pathology before the person, that could apply to their pathway. So hopefully they have imaging fairly rapidly, depending on where they've had their stroke, paramedic care, emergency department, and then pretty soon you'll understand which of the arteries or areas is affected, and that may lead to more efficient services and the people that health professionals that they'll see. So that's an interesting point. Can we define upper and lower motor neuron? Only because students ask me that a lot, and in my role, I see the students before you do. So students are learning their musculoskeletal physiotherapy. They haven't learned neurological physiotherapy yet, but I really want to go back to basic principles here in this episode. And let's make sure everyone's clear on all the different terminology. I've got another one before we do that, infarct.
Okay. As in what is the
let's do the basics, infarct and hemorrhage. Let's talk about the pathology.
Yeah, okay. So, all right. So a stroke, there are two different types of stroke. So basically all strokes will lead to what we call ischemia. Now ischemia just means cell death. So when someone has a stroke, they will have an area of ischemia because of a lack of blood supply where the cells will die. And they, those particular cells in the ischemic area, they're not recoverable. They're not coming back. There are two ways that people can have a stroke, or two sort of pathologies, if you like. The most common one is what we call an infarct, which is known as a blockage. So where the blood, a particular blood vessel to the that supplies the brain is blocked by a blood clot. So that's called an infarct. That is the most common type of stroke that people will have. The other type of stroke that people can have is what we call a hemorrhage, which is a bleed, where a blood vessel that supplies the brain actually bursts and starts to bleed. That can be it's most commonly related to development of an aneurysm, so weakening of the vessel wall. And, that can sometimes be genetic. Sometimes people are just born with aneurysms. More commonly, those aneurysms develop over time as a result of hypertension. So that's one of the reasons why high blood pressure is a really significant risk factor for stroke. And sometimes that bleeding can sort of be traumatic as well. It can be induced by traumatic reasons.
And recognition of the early signs of stroke has been something that around the world has been has hit the mainstream media. It's quite well known. Just to segue again, how do you recognise a stroke?
Yeah, so it's a really important point, and I'll speak first of all about the timeliness. So over the past, I'm going to say 20 years, there has been some really great developments in medical intervention for stroke. One of the developments has been introduction of drugs called, you can call them clot busters. TPA is a very common one, tissue plasminogen activator it's called. So I talked about infarcts or the blockages, if someone has a blockage in a vessel supplying the brain. If patients can get to hospital within 4 hours of the onset of stroke, then they may well be eligible for administering TPA. So this is what we call a clot busting drug. So it literally, as the name implies, breaks down the clot and restore blood supply. So it's really, it certainly was really groundbreaking when TPA came onto the market and was found to be safe and feasible. But it is only safe and feasible, A, if someone's had an infarct, and B, if it's administered within that short time window. So if TPA was to be given to somebody who's actually had a hemorrhage instead of an infarct, then it's obvious as a clot busting drug, it's actually going to make the bleeding worse. Similarly, in terms of that time window, we know that if that clot busting drug is given after 4 hours, then again the risk of bleeding, secondary bleeding, is actually really increased. So that's medication that can be given. The other thing that can be done for people, or performed for people with an infarct, is what we call interventional radiology, and this is a really specialised area. Only now, I'm going to say there's a couple of major hospitals, certainly in Melbourne, where I'm from, that are using interventional radiology, where they can actually go in with instruments and dissolve the clot. So rather than doing it medically, they sort of do it surgically or endoscopically. And I can't remember if that actually answered your question. Sorry.
That's it.
Because
Excellent
we started
information.
talking about upper motor neurons and lower motor neurons, and then we segued.
We're going to finish with how all this information crosses over into other areas, but this is really valuable. Let's not miss out on the basics.
Sorry, and you did ask me about signs of stroke.
Yeah, let's do that now. Signs of stroke.
Okay. So that was a long way of saying that's why knowing about signs of stroke is really important, because the sooner that people can get to hospital after they've had a stroke, it has a huge impact, can potentially have a huge impact on their functional outcome. So we talk about the fast signs, so looking to see if somebody has a facial droop. The other thing is to see if they can lift their arms, to see if their arms have been affected. So that's what the A stands for. If someone's speech has been affected, so if they suddenly starting to slur their speech, or if they're having trouble finding words. If they're having trouble finding words, just interesting that's often a sign that the Wernicke's area has been affected. So they're having, other way around. Sorry. The Broca's area. If they're having trouble finding words and expressing themselves, it's a sign that their Broca's area has been affected. And if they're having trouble understanding you, so if you're talking to a loved one or somebody and they can't actually understand you, that suggests that they're having trouble interpreting language. It might be a stroke affecting their Wernicke's area. Anyway, that's getting a little bit too complex. The important part is look at their face, see if there's any asymmetry in their face. See if they can lift their arms, if there's any asymmetry in being able to lift up their arms. Speech, as I talked about, and then the T stands for timeliness, which means, get them to hospital quickly.
Do it now.
Yeah, interestingly, and again, I can mainly speak from the Melbourne experience, but I'm sure that this has been probably replicated throughout Australia, is that we have a couple of what we call stroke ambulances in Melbourne. That are fully kitted out. They're essentially like a mobile emergency room. So if somebody had a stroke and is fortunate enough to actually have access to a stroke ambulance, the CT scan can actually be done in the ambulance, and they can start the clot busting drug in the ambulance. Which is pretty amazing. Like they don't even have to get to hospital yet. I mean, they will ultimately get to hospital, but the treatment can start straight away. can I just talk about the CT scan for a start?
Please do. Yeah, go for it.
So just to, I talked about the importance of, you can't give TPA to someone who's having a hemorrhage. It can only be given to someone who's had an infarct. So the importance of that early CT scan is to see whether someone's actually having a hemorrhage. So in terms of CT scans, within the first 24 to 48 hours after stroke, interestingly, you won't see an infarct. You can't actually see the impact that the visible damage to the CT scan on the CT scan doesn't show up until usually 24, 48 hours after stroke. But what you definitely will see is a hemorrhage. So if somebody is hemorrhaging, you will see it on the CT scan, and then, the medical staff know, obviously, not to give TPA. There are a couple of stroke ambulances that are operating in Melbourne, and as I said, I'm assuming it's a model that is probably being rolled out across Australia and in other but my guess would be it would be limited to capital cities at this point.
Which is an issue related to equity of healthcare, and one of the reasons why in certain geographical areas you have more opportunities. But I guess you prove the effectiveness of that model, and then it gets the funding, and then it gets more widespread rollout. Before you said maybe we've gone too complex. No, I think that was good. We're going through the signs of stroke and the FAST acronym, and then you gave us a little bit more information on the Broca's and Wernicke's area, and that finding words and the specifics of speech. And we do have a health professions audience, so it's fine to go into that extra detail. Let's come back to upper motor neuron and lower motor neuron. So somebody has a stroke, and you said it's really important for you as you enter the rehab phase to consider upper versus lower motor neuron.
Well, no, can I clarify that?
Sure.
So stroke is definitely it's an upper motor neuron pathology. So when we think about upper motor neurons, essentially I think about brain and spinal cord. So it's the cortex and all the tracts and all the upper motor neurons come down from the brain, from that I was talking about the cortex before, and things like the motor strip and sensory strip and the language areas that sit in the cortex. From that point, you have tracts and pathways going from the top of the brain there down into the spinal cord, and then intersecting at the level of the, it's just going out of my head, anterior horn cell in the spinal cord. So from the anterior horn cell out into the muscles is what we call the lower motor neuron pathway. Yeah. So there's that intersection in the spinal cord at the level of the anterior horn cell. So when I talked earlier about, when I'm looking at someone's pathology, whether someone has a pathology that affects their upper motor neurons, so stroke, for example, traumatic brain injury, MS, versus someone who has pathology that affects their lower motor neurons, such as, for example, Guillain-Barré syndrome, then again, their impairments and potentially their activity limitations, but certainly their impairments will be different. So, for example, in a lower motor neuron lesion, there is no spasticity. So we only have person will only have spasticity if the upper motor neuron has been impacted. As a diagnostic thing, so in terms of, when medical staff or potentially a physiotherapist are making diagnoses between an upper motor neuron and lower motor neuron pathology, then reflexes becomes important as a diagnostic tool. So someone with an upper motor neuron lesion will have very brisk, hyperreflexic reflexes, whereas someone with lower motor neuron will have absent reflexes. So that's, I haven't gone into lots of detail there, and that, there's lots of information that people can find out about upper motor neurons and lower motor neurons. But essentially, I think the easy way to think about it without going into too much detail is anything that affects the brain and most of the spinal cord is probably an upper motor neuron lesion, and anything that affects from the anterior horn cells out to the muscles is a lower motor neuron lesion.
That's a really good, clear explanation of that. Can we relate that to musculoskeletal physio who's performing a neuro screen, and they're doing reflexes, power sensation, as just a general screen,
Mm.
and they're performing their reflexes, and they're concerned about reflexes being brisk or increased versus
Yeah.
decreased and absent. Why would a reflex potentially be decreased?
Okay, so in terms of, I'm just trying to think where to start. In terms of the reflex, when you have a lower motor neuron lesion and you have decreased reflexes, it's because the reflex arc has been impacted. So if you think about the reflex arc that goes from the periphery, from the muscle, up into that anterior horn cell in the spinal cord that I talked to you about. So that reflex arc sort of just chugs along by it does its thing, and it just, the input comes in from the periphery, and then the output goes, out to the muscle to contract, for example. The quads tendon is an easy one. You hit the quads tendon with a hammer, you stretch the quads tendon, that information gets sent up to the anterior horn cell in the spinal cord. The anterior horn cell says, oh, the muscle's being stretched, let's contract it, bang. So that's essentially how a reflex arc works. If that reflex arc is interrupted at any point, then it will actually just go away. It will just stop working. So that's when you see that reflexes will be decreased, absent or decreased. And I think it's a good way to think about, a good way to get your head around it is to then think about, okay, so a reflex arc can just sort of chug, it's acting sort of fairly peripherally. Sorry, I can't say that word very well. In the periphery, and it just chugs along, but it has the oversight of the upper motor neuron. So the upper motor neuron can sort of control that reflex. It can modify it. It can increase it, it can decrease it, it can modify it. And that's how we actually get to participate in life without our reflexes constantly having our muscles firing at inappropriate times. So in an upper motor neuron lesion, that sort of oversight, that central oversight of that reflex is taken away. And that's when the reflex can just, left to its own devices, can go a little bit nuts, and that's when it becomes hyperreflexic, when it doesn't have that oversight of the upper motor neuron sort of calibrating it and controlling it. So just to recap, in an upper motor neuron lesion, those reflexes are left to their own devices and become hyperreflexic as they just sort of keep spinning around and, doing their thing. In a lower motor neuron lesion, the actual reflex arc has been disrupted and the reflex just doesn't work. Like, it just doesn't happen anymore. So that's when you get the absent reflexes. So
fantastic.
Can I just say, so as a musculoskeletal physiotherapist, and this is actually an interesting point, and I often say it to my students, as a neurological physiotherapist, I never test reflexes because and the reason is because they're diagnostic. They don't actually impact on function in any way. So as a neurological physiotherapist and I need to clarify, I don't work as a primary contact practitioner. I work in the acute setting. So I know my patient's diagnosis. And if we don't know the diagnosis, by and large, that's a medical staff, they're going to do their imaging and their clinical tests and all that sort of thing. It's not really my job as a physiotherapist in the acute setting to diagnose. So that's the reason why I actually never do reflexes, because they don't give me any information. I know my patient's had a stroke. I know their reflexes are going to be hyperreflexive. I don't need to test that. But as an outpatient physiotherapist, and this would, whether it's you're a neuro outpatient physiotherapist or a musculoskeletal, whoever, you absolutely need to check reflexes. Because in a musc outpatient clinic, for example, if your patient comes in with, back pain, some radiating pain, and some weakness in their dorsiflexors, then you need to know whether that weakness is a lower motor neuron weakness, perhaps related to a disc protrusion at L4, for example, or whether in fact that weakness, if they actually are hyperreflexic, then you're thinking, oh, actually, this isn't presenting as a lower motor neuron lesion. it's looking like there's upper motor neuron involved here, that's when you need to refer off.
Now we have that foundational knowledge of anatomy there, and somebody's testing their reflexes as a primary contact practitioner. They've determined someone's hyperreflexic or has absent reflexes, for example. What's next?
Well, it depends. If they're hyperreflexic, if they're demonstrating signs of an upper motor neuron lesion that hasn't previously been diagnosed, they need medical intervention. They need medical intervention or medical assessment, if you like, to find out what's going on, why they're getting upper motor neuron signs. If they've got lower motor neuron signs, so if the reflex arc has been impacted and they've got decreased or absent reflexes, then, as a physiotherapist, you need to use your skills to you are a lot more diagnostic in this situation. So, it could, I'll use L4 as an example. It could be that you find that, someone does have some weakness in their tibia, for example, and they've got decreased reflexes. They've got, a mechanism of injury that sort of describes a discogenic or would lend itself towards a discogenic type of pathology. Then, you need to make a decision as a physiotherapist as to whether do they need imaging to see what's impacting on the L4 nerve root, or are you, with your testing and with the mechanism of injury, are you confident as the physiotherapist that probably it's a bit of a disc protrusion or an osteophyte or something impacting on the nerve root that is explaining the symptoms? Sorry.
Go ahead.
I was going to say sometimes, you may, so there's not as much of if there's upper motor neuron signs, there's a sense of urgency. If there's lower motor neuron signs, it's probably not unexpected with something, with something like a disc protrusion or osteophytes or something else impacting on the nerve root. However, certainly if let's say someone has tibial weakness, for example, if that's, new and sudden and getting worse, then absolutely the person needs medical assessment.
That was my point. And we teach the students to consider their reassessment, the overall clinical picture, and judge that sense of urgency. But anytime you're picking up on something that's abnormal, you don't necessarily need to, or sometimes you can't diagnose it. But all you know is that something is abnormal. And if it's affecting the neurological system, there's a real chance that that person will have ongoing deficits from that. So don't ignore it and do the neuro screening and get good at that, doing that quickly. That's something that we do with the students before they reach you. They've had that basic understanding of neuro. Well, they've got deep understanding of neuroanatomy and that basic understanding of neuro screening that they can apply to a private practice.
Yeah.
So another concept we have on our list to discuss is this concept of neuroplasticity. Which is really important for understanding neurological events and injuries and rehab. So what's neuroplasticity?
In a nutshell, it's the ability of the brain to reorganise and change in response to demands placed on it. So I still find this a really exciting concept. I don't know if my students still find it as exciting as I do.
I'm sure they do.
The reason I find it so exciting
I'll ask them.
is because when I trained and when I qualified, we didn't know anything about neuroplasticity. In fact, the general feeling, the general knowledge, if you like, back then was that the brain couldn't change and the brain couldn't actually do. I feel like I talked a little bit about this on another podcast, so I'm sorry if I'm repeating myself. But back in my day, we were told that the brain could not change and reorganise itself, that it was stuck, that it had no plastic ability, which sort of didn't make sense because once I went out, and started practicing and working with people with neurological pathology, it became very clear to me, as it had been to many of my predecessors, I'm sure, that something's changing. The patients are getting better.
Why was that? Was it just a belief that, or I guess an understanding rooted in pathology and anatomy, that once you had damage to neural tissue, that it wasn't healing, but they weren't considering the growth of other neurons and in and around, and the adaptation that now we know is how people recover.
Absolutely. And I guess we are talking history here, and even I would say now, having looked at some of the historical evidence around neuroplasticity, that it was known about many, many years ago, but unfortunately, a lot of things in research, especially many years ago, a lot of this knowledge took quite some time to filter down into clinical practice. So I'm not saying that neuroplasticity was only discovered sort of 25 years ago. I don't think that's right, but certainly in the, clinical awareness and the understanding of how it impacts on people's recovery has really just exploded in the last, I would actually say in the last 10 to 15 years. So what is it? So as I said, it's the ability of the brain to change. Now, and I'm going to go with stroke because it's the most common pathology and it's sort of the easiest to wrap your head around, I think. When somebody has a stroke, as I talked about earlier, there's an area of cell death. It might be a little area, might be a big area, depending on the person and the type of, the size of the stroke. But that area of cell death is not going to change. That is not salvageable. What happens though after a stroke is there is an area around that ischemic area called the ischemic penumbra. So that's a fancy name of saying there's sort of an area around the unsalvageable dead cells that is actually still viable, still sort of neurons that are still clinging on to life. So they're damaged, but they're still viable. And then there's the healthy brain tissue, around the rest of the brain. So certainly in the early, the really early days after stroke, we think what's happening is the impact on that ischemic penumbra. So can we actually salvage those damaged but still viable neurons to sort of limit the amount of damage, if you like, in the brain? And so as recovery continues, that ischemic penumbra and the healthy brain around it will change and adapt, make new connections or unmask connections that were already there but have not actually been used before. And when I talk about connections, I talk about, the connections between neurons with the dendrites and the axons. They will all start to remodel after something like a stroke. Now, this is a really important point, and you can look, there's a lot of physiology around, as I said, the unmasking of previously silent synapses, creation of new synapses are things that we now know happen after a stroke or a traumatic brain injury. Where this becomes really important clinically is that the brain will adapt in response to whatever whatever you're asking it to do. So if I go in as a physiotherapist and I'm working with a person with a stroke, and let's say they've got a right hemiplegia, for argument's sake, but let's say they're having a lot of difficulty moving their right arm and leg. So if I not that I would ever do this, but if I did just go into that patient and say, having difficulty moving your right arm and leg, let's do everything with your left arm and leg, the brain's going to go, okay, all right, it's all about the left arm and leg. So all that really important and rich remodeling and reorganisation in the brain is going to go towards powering up the unaffected arm and leg. And that's what we call learned non-use. So if you don't actually so I think what's really important when I talk to my students about, and this is where I get really excited, is that we can drive recovery. So we can actually drive that reorganisation by demanding the system, if you like, or encouraging the patient, facilitating the patient to use their affected side as much as possible as early as possible. And then, as I said, you really start to drive recovery and get those connections happening in a way that drives use and awareness of the affected side. And I find that really exciting.
It is. That's amazing, isn't it? If you think about what's going on, it's fascinating. Some of the exercises may be simply doing movements and encouraging functional movement and activities and sensory stimulation on that side. But if you think about why you're doing it and the reorganization that's happening in the brain, and
you're actually driving neuroplasticity. That gets me out of bed every morning, Luke.
Yeah, in that ischemic penumbra where a lot of my house plants live
and
as
also
well.
the healthy brain also as well. Not just that ischemic penumbra, but also in the healthy brain that's that hasn't been affected. Because that will change, that will adapt and change as well.
So you've been working for many years and you've got this passion for what you do as an educator and as a clinician, and that really shows through, and it's what people like listening to you. Let's go back to the student or the grad who's still learning all this stuff. Maybe that you've just graduated. Where should clinicians start? So perhaps postgrad courses and networking. Where would you direct them to?
It's really, so in terms of neuroanatomy, I was not very good at it at university. I didn't understand it very much when I was a student. And I think for me, as a student, and this is going back a few years, it was all textbooks. There was nothing online. There was no videos. There was no
no podcasts.
Oh, yeah, there was no podcast. And it was all very dry, and it was all a bit of rote learning. Wow. And it wasn't until I started my new graduate role and was fortunate enough to do neuro rehab as my first rotation, and then acute neuro as my second rotation, that I went back to my neuroanatomy and went, okay. So yes, and I don't have sort of postgrad courses for neuroanatomy on the tip of my tongue, but I'm sure that there are, and there's lots of great resources for neuroanatomy that you can search online. But what I would say, certainly if you've got some experience or working with patients with neurological pathology, always just loop back to your neuroanatomy. The basal ganglia. Okay, Parkinson's disease, basal ganglia disease. That's why they're having these impairments. Because I think that as I said, I really wasn't very good at it as a student, but it really starts to make sense when you've got a real life person in front of you with particular impairments and activity limitations, that you can then loop back to their neuroanatomy. You just mentioned resources, and as I said, I don't have resources about neuroanatomy on the top of my tongue, but I could find some. There are lots of amazing resources and lots of amazing Australian resources for health professionals, and also really importantly for patients and their families online. So, for example, the National Stroke Foundation in Australia has two wonderful websites. One's called Inform Me, and the other one the Inform Me is for health professionals, and that's where you'll find the National Stroke Foundation guidelines, which we haven't talked about today, but they're living guidelines that give you really up-to-date, evidence-based, everything from, medical treatment, preventative technique approaches for preventing stroke, right through to obviously acute care, rehabilitation care, all that goal setting and things. Then they also have a site, sister site, if you like, called Enable Me, which I probably look at even more than I look at Inform Me. That's the one for patients and families, and I love it. I just think it's amazing. So that's got lots of really fantastic information, videos, guidelines, goal setting, how to set goals for yourself and things. And that's a really good resource for patients and families. And I think needs to be front of mind for anyone working with people with stroke, in terms of referring or alerting people to these really evidence-based, accurate, up-to-date great community building, online resources as well. I think it enable me, there's a lot of people with stroke who contribute to that page and put up videos of their recovery thing. And I love it. I think it's fantastic. Similarly, there's new guidelines, Australian and New Zealand spinal cord injury physiotherapy guidelines have just, they were released either 2024 or 2023. They also have resources available for patients and their families, written in more sort of patient-centred language and obviously, evidence-based guidelines for physiotherapists and other allied health professionals as well. So they're just sort of two examples. There's amazing resources around functional neurological disorder, for example. There's some great resources, again, for patients and families and I can give you names if I'd have to quickly Google it and remember. I think it's called FND Australia. There's a few of them.
We can add anything you'd like into the show notes. We've got
perfect.
Inform Me for health professionals, Enable Me for patients and families, the new guidelines for spinal cord injury, other things that you'll think of afterwards. We'll put them all in a big list in the show notes so people can go and look at them.
Perfect.
And just it's been a really interesting conversation. I've been thinking about those fundamental foundational principles, neuroanatomy, pathology that you've been talking about, and how these impairments from a neurological perspective can seem quite mysterious if you don't understand the brain and the spinal cord and the anatomy and its function. And that provides that foundation of understanding what's happened. And then if we go back to your previous episodes, we can really think about patient-centered care and putting the person in the middle of that care. And you had some interesting stories related to how you be a patient-centered health professional. So people can go back and listen to that.
Yeah. And can I just add there, if I picked up on your word mysterious, if you don't know your pathology and your neuroanatomy and things are mysterious to you, like, I wonder why the patient's got that impairment. I wonder why they can't look to the left. Imagine how mysterious it is for the patient.
Right.
So it is absolutely our responsibility to provide education to help patients and their families understand, weird deficits like neglect, like why are they constantly looking to the right all the time? I come from the left and they don't even notice I'm there. Why is that? Why is their arm hanging over the end of the chair, even though they can move it? They just seem to completely not. What's that? I'm describing left neglect there. And if you don't understand it as a physiotherapist and you don't understand why it's there, what it is, and help, provide that patient and their family with that framework, that understanding, that education. We know what this is. We know why it's happened. We know how we can help recovery. Then, you're all walking around in the dark and it's really hard. And I think it's an incredibly important, I think education, and I struggle. Sometimes my students say, they'll be in simulation and they'll say, I provided my patient with education, but it was sort of just this, stream of words at the patient. There's lots of ways that we can provide education to the patient, and it really needs to be, at their level, at their time, with resources that make sense to them, in language that makes sense to them, and when I say language, I mean in terms of the types of words that we use. And then, of course, we will work with many people for whom English is a second language. So actually, again, providing resources in appropriate languages, all of those sorts of things really come into play. But I think, as I said, if neuroanatomy and pathology things are mysterious to you, then I think that's problematic for the patient and their family.
But likewise, if you approach that learning with curiosity.
Oh, absolutely.
And then fill those gaps with all the work that's been done in research and education and producing those patient and health professional resources, then you can go on that journey with the person. You can learn from the patient, learn from the person. You said the Enable Me resource has lots of input from people with stroke as well. That's really important. It's not just produced by someone who's giving you a lecture.
Absolutely. And I'm just going to try, because I was actually just looking at it before, because as I said, I actually look at it more than I look at I'm just looking at, so I'm just going to give you an example.
Go for it.
So resources. So on Enable Me, the patient and their family can click on, I'm new to stroke. So there's things like what to expect in the first few days, who will be involved in my care, what are the types of stroke, what are the procedures, younger people. So just a reminder to everybody that younger people have strokes, childhood stroke, getting good health care and questions to ask. Then there's a section on body and mind after stroke, so how the stroke can affect you, exercise, vision in the sense, it's amazing. My life after stroke, carer information. There's a great section on goal setting. There's also a great section called I Rebound, which is all about, after stroke, moving well and eating well after stroke, and the absolute imperativeness, I don't think that's a word.
It is now.
Sure. Importance of exercise after stroke.
Yeah.
There's a lot of resources there, and I think the National Stroke Foundation have done an incredible job.
And a big part of your passion for what you do in your career must be the evolution, the rapid evolution, the improvement in our knowledge, but also what's available for people.
Yes.
And what we can then pass on to the students, and then they can build on in the future.
Absolutely. And I think going back to the resources like Enable Me, they've become more and more important because patients aren't staying in hospital very long. So back in my day, patients would, stay in hospital almost as long as they needed to, really. And, and that landscape has shifted dramatically, especially in recent years. So
the hospital is scary, but likewise going home quickly after hospital with a whole bunch of new problems is scary. And these resources really help people and their families to cope with that.
Yep, absolutely. I think they're incredibly important and should, just a given, every patient should be pointed in the direction of these types of resources, I think.
If we did another podcast episode, what would be some pet topics you'd like to talk about? Let's do some foreshadowing. I reckon we're going to do it again one day.
We could talk about people with specific pathologies, if you like. We could talk about, I don't know, honestly, I could talk about anything. We talk about, the importance of task-specific training.
It would be good to explore the rehabilitation and some of the practical aspects of different impairments, not just motor, but some of the other impairments and how they impact on people's function and some tips for people who are currently working with people with neurological conditions. That would be really good.
Yeah.
Move into the rehab space.
Yeah. And I have a lot to say about assessment, about neurological assessment. And sort of, the clinical reasoning behind assessments. And just to round out our discussion, we've talked a lot about impairments today. I've mentioned the word activity limitations, so functional problems, if you like. But really what's ultimately most important for the person, for the patient, is being able to participate in their daily lives. So we, as physiotherapists, we need to have, what are the patient's participation restrictions? And that might be, that I can't go to work at the moment because I'm unable to drive, or, I'm now in a wheelchair user and there's no ramp at the front door, so I have to work from home. It could be that I want to go to the MCG to watch the footy on the weekend. I need to be able to catch public transport. I need to be able to look after my grandchildren. So, working out what's most important to the patient, and what's most meaningful for them, and then working out how we drive recovery to enable them to do whatever is most meaningful for them is really important. And again,
it's a really good place to come back to next time.
Cool.
Thanks, Narelle. I found that I've learned a lot. I actually sat back a bit and I asked some questions that I did know the answer to as well, and I asked some questions that I didn't know the answer to. And it was good to just let you rip on a topic that you're really passionate about and have many years of experience in. So thanks again.
Pleasure. Always a pleasure to chat to you and to chat all things neuro. Thanks.
So everyone, thanks for joining Narelle and I in this conversation. If you find someone, if you're working with someone or you know someone who's a health professional or health profession student, they don't necessarily have to be a physio student, but somebody that you think will find this episode helpful, please share it with them and do let us know what you think. I've just asked Narelle what her next episode topic could be on, but we'll base what we do on your feedback. So keep sending me those emails and DMs and let me know what you think about the episodes. And until next time, this is Narelle Dalwood and Luke Periton wishing you all the very best with your studying, professional development and lifelong learning.